I'll definitely be here for the next couple of days. So Fridays, no guarantee if I'll be here or not. In fact, I know at least part of the day I will definitely not be here. All right. Questions. So we have a heart. We got systolic function, diastolic function. Second quarter, we started with contrast, specialized techniques. We got aortic valve, mitral valve with all of their intricacies, prosthetic valves. I'm just going off memory here. So we've got, I think we did coronary stuff, heart attacks, dilated cardiomyopathies, hypertrophic cardiomyopathies, pericardial disease, aorta, masses, tumors, et cetera, et cetera. This could be some short review. I like it. When is Tammy's test? Is that Monday?
Monday.
Okay.
And how much
Yeah,
more
Monday.
do you want?
Is that Mike? I heard somebody asked a question.
It might have been Sarah's family background camping.
Might have been somebody putting something on bread again.
Scott, you said that this test is more heavily focused on the second half of the quarter, right?
Correct. Yes.
Okay.
So yeah, about 2/3 of the points are going to come from the second half.
Good to know.
Are you going to record this?
I usually don't record review sessions. Just because if people are going to be reviewing, I think they need to be in person for that.
So,
Well, but if you record it, we're here in person, but if we want to go back and review what we discussed today, can we just record it for that reason?
I can, yeah. It's just I usually do that for an equity standpoint, just so that people aren't skipping out on the review sessions. Because I feel if you make the time and effort to be here, it's. But either way, it's fine with me. Because if people don't make the effort to be here and they get the benefits of it.
Scott, for the exam, final exam, do you include a picture of pathologies like thrombus or something?
There can always be. It's no different than my other tests. So there might be the odd pictures. I usually don't do too much weight in pictures, but there certainly could be some.
so I got a specific question about both vegetation and masses and tumors.
Sure.
So post-surgery, typically we can see like vegetative growth due to infection, but we can also see like hematoma. So how would we be able to tell the difference between those? Or is it just like they have to go in there and check or clinical and blood tests, and we can't tell the difference?
So how do we tell the? Sorry, state that again. So it's how do we tell the difference between vegetation, thrombus, and masses?
Kind of specifically like post-surgery for hematoma, since I know post-surgery we're more likely to have vegetations due to possible infection.
Correct. Yeah. Yes. Now, when they do surgeries too, hopefully they're treating with antibiotics and stuff before and after they do the treatment. So we do reduce the chance of that pretty significantly by treating the patient appropriately. But what we're going to look for, if it's thrombus, the thing we're going to always look for in thrombus is looking for stagnation of flow. So if there's anything still causing a restriction of flow and pooling of the blood and stuff like that, we are going to be more concerned about thrombus. Blood tests would certainly be validated to, if we do suspect vegetation, to rule out whether it's a vegetation or not. So if they're truly concerned about that, they would certainly be doing a blood test to verify that. Obviously, masses and tumors aren't going to be too big a concern. There's going to be typically scarring and stuff from the surgical sites. So we might get a little bit of a lump formation because of that, but that doesn't mean it's like a cancerous type of tumor or anything like that. It's usually just a nodular type of spot where they attach stuff together. So in most cases, we're probably dealing with thrombus and or just overgrowth of that that scar tissue. You guys have all seen like where somebody's had like a surgical procedure or something done on the skin surface, and sometimes you get that nice small amount of scarring and stuff like that. There's always a bit of a residual line, but sometimes you get those kind of a lumpy formations and stuff like that also. So that could certainly happen inside the body as well. We're not super concerned about those as long as they're stable and not causing inflammation or degradation of tissue and stuff like that. Does that answer your question?
Yeah, for much. Although it brings up another one, like how can we tell the difference between well, I guess it would just be looking at patient history, seeing whether the scarring is due to pericardial disease or past surgery. Kind of.
Right. Yeah. Yeah. I mean, it kind of depends on what the patient has had done recently. And the other thing with thrombus and stuff like that, many of the surgeries have transesophageal going at the same time. So we actually look to see that wall motion and stuff is still good, that there's not pooling of blood and or thrombus formation before they seal everything up. So, if they're surveilling it that way, it's certainly less likelihood of those types of things happening. But, because the way the human body is, we actually will be taking those precautions again with antibiotics and different things pre and post surgery and during surgery. Try to minimize that risk. Now, if you're in a different country where they may not have as much access to that type of stuff, then there's certainly a bigger chance of that stuff happening.
Makes sense.
Yep. And or drug resistant strains of bacteria that get introduced. So, as you go through the summer into your surgical asepsis class, take that pretty seriously, because when you are in a surgical situation, just even the smallest amount of contamination of the field can cause somebody to get this introduced into their body, and it can be certainly devastating to that patient. So our sterility, our keeping the field sterile and stuff like that, and making sure that our equipment is clean and good is really, really important. Now, in a surgical setting, there's often a nurse or somebody there that's kind of surveilling everybody and making sure that they didn't contaminate the field. In fact, I was talking to a friend of mine who's a nurse that worked in an OR. He was, what was he? I think he's a surgical nurse. And he was in some other procedures and stuff. And what he was tasked to do when COVID was all fresh, his task was actually to go in and make sure that people were having sterile technique and stuff. And he's like, even people that do stuff on a regular basis, he was catching them all the time, contaminating their field, whether they're touching their mask or touching equipment and then something else, or, whatever it was. That was kind of his job, was to be the infection control police, so to speak. But it's amazing how many times just out of habits that we do things and we touch things, but you got to be very careful of your sterile field.
Okay, well, I kind of have a more broad question for overview.
Go for it.
I would say the least topics that we've learned from the second half of the quarter here is just all the cardiomyopathies. I don't know why I have a hard time with those chapters, but I can read those 2 chapters and like parts of them over and over again, and they still are hazy for me. So like
Okay.
dilated cardiomyopathy, there's ischemic, there's non-ischemic, there's restrictive, there's constrictive. They all just kind of like get confusing.
Okay.
So I know.
Let me attack restrictive first of all. So on all these cardiomyopathies, we get introduced, and this is kind of going back, flashback to the first quarter with diastolic function. So with a lot of these muscular type things in particular, we are going to have diastolic dysfunction issues. So that's a pretty broad spectrum. So let's quickly review diastolic function. So what is the basis of diastolic function? How do we measure it? How do we evaluate it? And what are the stages of it? And what are the, different levels of it? So let's start there.
So I know that with diastolic dysfunction, you have an impairment in relaxation. And with that, our main things that we evaluate is mitral valve inflow, particularly evaluating the E and the A and decel time, as well as TDI and pulmonary vein flow. There's 4 stages. There's impaired relaxation, there's pseudonormalization, there's non-reversible restrictive and irreversible restrictive.
Yes. Okay. Good. So in some degree, we're going to experience some are either early stages of that or advanced stages of that. In most of these dilated cardiomyopathies, even hypertrophic cardiomyopathies, we're going to have some type of relaxation issues. Just because the muscle might just be bulky and stiff, or because inherently the muscle tissues aren't working right, like in a dilated cardiomyopathy, and it's just not functioning the way it should. We know that the diastolic dysfunction affects the pressures in the heart. So remember, as part of the diastolic tables, we also look at things like the left atrial pressures. So those get more and more increased. Those pressures get more and more increased as we progress down the worsening of the function towards the restrictive. And so, so we're going to evaluate size of chambers and stuff like that. Also, don't forget that part of that can be using Valsalva technique on the mitral inflow, and also using propagation velocity on the color M mode. So that may be part of your diastolic function evaluation. But yes, generally speaking, mitral inflow, those waveforms that we measure, comparison of the E and the A to each other, but also comparison of the E wave to the mitral annulus E wave velocity. Deceleration times, yes, we could also be into IVRT, stuff like that as well. So that can all be part of that. So going to the restrictive physiology. So again, that's kind of end stage type disease. It's really getting out there as far as the progression of diastolic function or dysfunction. And so what do we get when we're getting that end stage disease? What is confused, or what could be confused with that when we're looking at other types of pathologies, specifically with the pericardium?
Is it the constrictive?
Yes. So definitely know the difference, the differentiators between the constrictive physiology and the restrictive physiology. So that's where you're going to get the look at the atrial enlargements and stuff like that. Looking at the function even. So if we've got constrictive physiology, remember that the issue is not the muscle itself. The issue is outside the muscle. It's the restriction of the sac around the heart. That's our major issue. So with that, the systolic function might be just fine. Whereas a restrictive, it definitely won't be, right?
Systolic won't be, or
Well, it's not going to be as normal as because of all the restrictions. We're going to have super elevated pressures and things like that. So the heart's not going to appear to be as responsive. It's not going to be definitely not the diastolic function part of it. In fact, the diastolic function in in that could be fine, except now in constrictive physiology, we're looking at the respiratory variation in it, and we're less focused on what's happening with E and A as much as what's happening with the variation of respiration with the E waves to E waves. But if you're looking at it from a visual perspective, the heart might appear to be contracting and relaxing normally, pretty responsive, kind of bouncy, but it's being affected by those pressures from outside the heart that are influencing it, giving it that mass effect, so to speak, on pressure. And that's where we get into the collapsing of the right ventricular free wall and right atrium and stuff during diastole. Does
Can
that
you-
answer your question, Kelsey?
Um,
Or do we need to explore that some more?
I would like some more exploring.
Okay, we can explore more. Nancy, you had a comment or question?
Can you visually see diastolic dysfunction?
You're gonna know. I mean, yes. This is where your scanning comes to. You'll get a gut feeling about how things are, whether it looks normal or abnormal, and you'll see a whole bunch of normal hearts, and you'll see how they normally respond, and you'll get a feeling for when it doesn't look right. And sometimes that's initially just a gut feeling, but when you get that gut feeling, pay attention to your waveforms and stuff like that, because that's sometimes where it reveals itself. And if we're not paying attention to it, then we might miss it. But often your gut kind of gives you a feeling that something ain't right, and you just kind of need to go looking for it. Sort of like the horror movies, something happens and you're like, don't go into that room. There's always something bad happens there. Well, yeah, you get that gut feeling. And in this case, we do want to explore it. In a horror movie, I recommend not. Nothing ever good comes of those. All right, Kelsey, you want to explore this more? What other questions do you have about that? What do you want to dig into on it?
So I guess just like main distinguishing factors between dilated and ischemic versus non-ischemic. I feel like that one I'm actually pretty good with. And then the hypertrophic, constrictive versus restrictive, more just like the main differences. I know
Okay.
with dilated, you're going to have chamber enlargement everywhere, and the slower blood flow everywhere with that.
Yes.
And for ischemic, you're looking for like a wall motion abnormality, like hyperechoic walls or akinesis.
Good. So let's go to the fundamental definitions of them to start with. And so how do we know for sure that it is a coronary artery disease issue? What are your things that can tell you that it is that? Because remember, we got our
Is
differential.
that regional versus global?
Yes. So if I've got definite regional segments out, we've now categorized it as a coronary artery disease issue. So if I've got, a couple of segments out on different wall segments, but other wall segments are fine, it's more than likely that. If it's global, we can't say for sure. So a global issue with coronary artery disease, if it's kind of equally affecting everything, but it's all depressed, it's all down, that could be thrown into the dilated cardiomyopathies, because we're getting dilated, the heart's becoming enlarged, stuff like that. The function is becoming worse, but we can't distinguish it at that point because we don't know for sure that it's a coronary artery disease process causing it. Now, with both dilated cardiomyopathies and hypertrophic cardiomyopathies, fundamentally, what do we need to make sure that we're not confusing with those? How do we know diagnostically it's one versus the other? Or how do we know diagnostically it's one of those and not something else? For example, can we have thickened walls caused by a process other than a muscle issue?
Yes.
Yeah, like leptomatous infiltration, right?
Right. So remember, independent of valvular disease or significant hypertension, systemic hypertension, stuff like that, those are going to cause wall thickening, for example. So if they've got like a super aortic stenosis, that's probably more of the reason as to why we're having these issues caused. Now, blood pressure, a significant elevated blood pressure, that is going to cause hypertrophic stuff going on. And remember that in the textbook, it kind of grouped that in with those idiopathic type that you don't really know what's causing it. So you might need to investigate that more. As opposed to our infiltrative type states like amyloidosis, those types of things. But remember, on a typical hypertension type of a patient, what is my wall thickness relative to what it would be on a truly hypertrophic cardiomyopathy? What are the wall thicknesses like? So they're all thick. But are we talking carne asada thick? Or are we talking Costco steak thick, right?
Like certainly hypertrophic is thicker than anything that we actually get through hypertension. Hypertension is, it's slightly thicker than normal.
Yeah.
or
So remember,
typical
so the
cardiac
cutoff
disease.
was that cutoff number was 13 millimeters or thicker. Puts it more into the hypertrophic stuff. If you're between 9 and 13, that's going to be more hypertension related, more than likely. So remembering our definitions of what it is, and remember that these are independent of these other disease states. And like the dilated cardiomyopathy, sometimes they throw in things like coronary artery disease, because if it's a global thing, that might be contributing to it. And we just can't narrow it down enough to know for sure at that point on echo alone. If they were to do a cath lab procedure and test out the pressures and put dye into the coronary arteries and stuff like that, they'd obviously have a lot more diagnostic differentiation. Nancy?
What view are we doing 13 in? Is that Plaques 2D?
Yeah, parasternal long axis, either 2D or M mode. They should be technically the same if you're doing them accurately.
I'm trying.
Right. Yeah. And honestly, most labs choose to either do one or the other. I have you do both because, again, for practice, and you may end up in a clinical site that requires you to measure it. I just want you to know how to do it effectively. In a clinical setting, you're probably going to do 2D, honestly, most of the time. My take home message for that, though, is that if you're doing 2D, make sure that your windows are good, because most people get lazy on that and they take it from a very low parasternal window. And my axis of the heart is more like this rather than level. And going back to the basic physics fundamentals, what is the difference? Which one is more accurate, being perpendicular to it or being off axis to it a little bit?
Perpendicular.
Perpendicular is always better. So my rule of thumb is even if you don't do the M modes all the time, keep your windows high because your accuracy of measurement is going to be more accurate. Now we're talking millimeters, but millimeters do make a difference. If we're 9 versus 10 millimeters, technically we're abnormal. 13 versus 12 is technically, one is more hypertrophic and one is just a thickening due to just a regular hypertrophy due to like blood pressure. So those millimeters can make a difference. All right, and then let me see, pericardial disease. I'm trying to see which slide set it's on for the comparison chart. I want to go to the table for your question versus restrictive and constrictive. Just trying, it must be part 2. Come on. Let me see. Sorry, I'm just trying to go through. There's a table here. Okay. Let me share my screen. Okay. So constrictive versus restrictive. So this table is kind of a nice table just to show the differences. And let's just go through these real quick then. So, and then we're going to differentiate the things that kind of really stand out versus those that kind of stand out. So atrial size on a constrictive is going to be normal. Restrictive is they're dilated, and they're both pretty significantly dilated. So if you remember some of those pictures that we showed, those atria were about 2/3 the size of the, or they're 2/3 larger than the ventricles were. So it's pretty significant size change in the atria on restrictive physiology. So let's talk about why that might be the case from a physiologic standpoint. So why do you think in a restrictive versus a constrictive physiology would those atria be so much larger?
Because the sac is kind of keeping it smaller.
Okay, so where does the pericardium go around the heart? Let's talk about that first.
Everywhere but the left atria.
Right, and it partially goes over the left atria, but yes, I mean, the left atria is kind of outside of the sac, so to speak, because that's where it's kind of anchored. The right atria is mostly contained within the sac, so that could be part of it. So let me attack it from a different perspective. When we have a constrictive physiology versus a restrictive physiology, which one is more of an acute process versus a chronic process?
Constrictive.
Yeah, constrictive is usually more acute. Okay, and what do we know about acute things in the heart?
Doesn't tolerate it.
Doesn't tolerate it very well. So, you know, so when we're talking about atrial size, think if it's a rapidly happening process, our atria are stretchable, but they're not that stretchable that quickly. So it's more likely to stretch due to a chronic type of a process than it is an acute type of a process. So even if we broke a mitral valve, for example, and we had a complete flail leaflet, this patient's going to be very symptomatic very quickly. But if I was to compare that with a severe regurgitation, compared to somebody who developed severe regurgitation over a long term, which one would be bigger?
The regurgitation over a long time.
Yes. So restrictive physiology is the same way. So think of restrictive physiology as the end of the line diastolic dysfunction. So it usually takes a longer process to get to that point. And because of that, we've developed this large atrial size because of a very long chronic process. Okay, so it makes sense that the restrictive would be a very large atrial size. And the atrial size is one of those fairly distinguishing characteristics between these two. Pericardial appearance. So let's talk about that. So which one has a brighter appearance in a pathologic state? So first of all, should a restrictive process have a bright pericardium?
No.
I mean,
No, it shouldn't.
abnormally bright. Okay. So let's again revisit one of our pitfalls, and that is, when is the pericardium bright? How can you tell it's bright?
By
always
progressive
bright.
damping.
Okay.
Yeah,
It's
the
almost
progressive.
always bright because we tend to not dampen our gains on the lower side of the TGC, which we should. So your TGCs should sort of look like a reverse C shape normally. So you typically have your anterior TGCs down. You have the mid one sort of up to enhance our signal. But because we have fluid enhancement causing that posterior enhancement behind it, we have to dampen the TGCs on the backside. Which sometimes often we forget, and we don't really pay that much attention to the pericardium, but we should. Our image grayscale pixels should be a similar gain from the front of the field to the back of the field. And so we should be balancing our TGCs all the time throughout the entire structure, so there's a similar gain pattern. That's how to appropriately use your TGCs. So if we constantly scan with it bright, are you going to notice a constrictive type of brightness?
No.
Probably not. So you got to clue in that something else is going on to catch it. So my soapbox moment here is to make sure that you're gained appropriately throughout your entire exam, paying attention to all these different things, because it is easy to miss stuff if we overgain it. It's also easy to miss stuff if we undergain it. So, you know, people say that I just like to have my images dark, and that's not true. It's, if I don't see the detail in my image, it's either too bright or too dark. It could be either one very easily. So we do have to notice it's thick. So a constrictive pericardial disease is a actual thickened inflammatory type of process. It does come across bright. We do have a very strong specular reflector, which makes it inherently brighter. But how do we tell pericardial disease versus restrictive pericardial sac? What do you do to diagnose that? Nancy's alluding to it with sign language.
Kelsey said it earlier too.
Yep. So it's that progressive dampening. Now, does that work well in 2D?
M mode's better, right?
Okay. Yeah. I mean, theoretically, you could see it and appreciate it in 2D, but you're going to see it live, and the doctor's not necessarily going to have a diagnostic marker for it. So M mode is better. And remember, with your M mode, to slow down or to slow down your sweep speed all the way, and show where you show a segment from that M mode before you dampened it to when you fully dampened it, to where the wall just disappears, but your pericardium is preserved. Okay, if it
This is
stays bright, it's bright. Go
slow
ahead.
sweep speed, is that a
If
higher
you-
number or a low number?
So that's usually 25 millimeters
Okay,
per second.
so it
Yeah,
is
it's the
normal.
lower
It's a
number.
normal number. Does a little mean slow? Okay.
Yep. So in essence, just like your tamponade, where you want to see the E wave variation during respiration, we want to see a very long strip with more information.
Then those are both slow sweep speeds, right?
Yes, correct.
Okay, cool. That's
Yeah,
a
the
good
only-
another connection. Thanks.
The only time we're going to increase our sweep speed is when we want to, when stuff is so tight and so sharp. Like if I've got really fast acceleration times, for example, it can be helpful, provided your doctor knows what you're doing, that you increase the sweep speed so you actually, show the slope a little bit more. If it's so packed together, it's sort of akin to measuring a very tiny waveform. If your measurements are so kind of cramped together, you're not going to be as accurate on your measurements. So if you want to increase your accuracy, like on an acceleration time or something like that, then you might increase your sweep speed. But you can make it look normal if you do that. So you want to make sure that your doctor is aware that you changed the sweep speed on it. Okay. But for measurement accuracy, that's why you might do that. Okay, so that's pericardial disease. So that's kind of one of those that is, it is a distinguishing thing, but from an echo perspective, it might not be a super convincing thing because we have a strong specular reflector. So that may not be one of the ones that's like, oh yeah, this is definitely constrictive versus restrictive. Whereas atrial size would be a big difference on that. Yeah, Nancy?
When you were saying earlier, you said you want to compare your mitral E to the A, but also to the annular. Were you meaning the TDI annular or
Yes.
the pulse wave at the annulus?
Well, it is so on the annulus itself is the pulsed wave for the TDI. So it's our E prime. The E
Okay,
prime
so
is
when you
the-
say annular, you meant E prime. Okay, I got you. Thank
Yes.
you.
Correct. And that's as far as diastolic function goes. And we do come down to the annular stuff here in just a little bit on that as a comparison. And that is one of our more distinguishing factors, is the annular velocities on these. Okay, so that's pericardial. Septal motion, again, septal motion and septal position. While those are sort of distinguishing factors here, they're not standout kind of distinguishing factors, because they're kind of still like, it might suggest that it is or isn't constriction versus restriction. So I'm just going to breeze over that a little bit because they're not the really standout ones. So the mitral E and A wave reversal. So with constriction, we increase greater than 2 or equal to 2. And remember, it's a ratio, so it's the E waves more than double the height of the A wave. But as you notice, that's the same on both constrictive and restrictive. So again, not a distinguishing factor, but they both have that feature. So if you're looking at possible constriction and you've got a normal E to A ratio, you probably don't have constriction at this point. It might have things progressing toward that, but it may not be there yet. So that's where it does, but it doesn't distinguish between the two. Short deceleration time, again, both of them have less than 160 milliseconds for that. So again, it's a feature that they might both have, but they don't distinguish between the two. Annular E velocity. So this one is another distinguishing factor. So the annular E velocity on constriction is normal, and that for the restriction is reduced less than 10 centimeters per second. But again, from my experience, I would say that these are actually more like 4 meters per second. They're very, very slow comparatively, because a normal E prime velocity is usually about 8 to 10 or greater centimeters per second. So when we get into impaired relaxation, pseudo-normal relaxation, those velocities progressively go lower and lower. As we get into restrictive, they get very low. Okay. So if we, going back to our gains and stuff like that, if we overgain, it's very easy to overgain our spectral Doppler to overestimate where these velocities truly are. Remember that when we're on a on muscle tissue or the annular type of tissue with a pulsed wave Doppler, how strong relatively is that compared to a blood flow velocity? As far as a reflector goes, which reflector do you think is stronger, a blood pool or tissue?
Tissue.
Tissue is definitely stronger. So these are very, very easy to overgain. So be careful on your gains on your tissue Doppler, and always be careful about that, because we tend to overgain it quite often. Okay. It's very easy to do, but we don't really think about it because we're on regular pulsed wave Doppler. We tend to like our stuff bright. Just remember that it's very easy to overestimate what's really going on. And if you overestimate on a velocity between, say, 15 centimeters per second and say 7 centimeters per second, is it hard to make that difference just because of gain? No, I mean, you can easily make it look like a normal velocity when in fact it's very abnormal. So be very careful on your tissue Doppler gains always. Okay. And I think for me, I just take that, I take that a little bit more so because in my day, that was pre system optimization, where they had presets that did tissue Doppler. We had to manipulate the tissue Doppler manually, and we had to do it by hand. And so you had to be very careful to not to overgain it. Now that the systems are very good nowadays, but we can still, we tend to overgain most of our Dopplers, honestly. Don't go too dark, but make it real. Your general rule of thumb on your spectral Doppler is for anything that's got a decent intense waveform, like any of your inflows or your tissue Dopplers and stuff like that, we tend to have good reflection on those. And so we tend to overgain it pretty easily. But the spectral background should be basically, you bring your gains up until you have specular reflection in the back. So just a speckle in the back of your waveform, but then you turn it down until that just goes away. And that's how you appropriately set your gains for spectral Doppler. Now on regurgitations, we tend to get faint waveforms with very tiny holes that are tough to pick up. So for that reason, we actually increase so that we do see some background speckle in those. And that's appropriate, because then when you're actually seeing those waveforms. But the intense waveforms, like your regular inflows and the flow through the aortic and pulmonary valves, those will be fairly intense, relatively speaking, and you want to bring that gain down so that your background is speckle free, and that's how to appropriately gain for that. Similarly with color Doppler, the appropriate use of color Doppler is to increase your gain until you see background speckle, turn it down until that just goes away, and that's where your appropriate setting is for gain for color. We often kind of ignore that, but that's how to appropriately use it. Okay, so far speaking, atrial size is a big one to differentiate between the two. and your tissue Doppler or the annular Doppler. Okay, pulmonary hypertension is going to be rare with constrictive, and it's going to be frequent with restrictive. So let's talk about the physiology of that. Why do you think that might be the case?
Just
Why do you
due
think it
to
would-
the enlarged atria backing up into the pulmonary vasculature.
Right, so we've got a significant amount of TR and probably some MR with restrictive because of those atrial sizes and its stretching. Why do you think it might be rare with constrictive?
Because you won't have that atrial enlargement.
Right, and it's because
You
of
can't
that
get the pressure.
Yeah, the pressure is just not there, so it's going to be a lot less likely. Even though everybody's got TR and stuff, but yeah, when we're looking at that, it's going to be hard to pick up your stuff. You might lean more towards the restrictive on this one if you're seeing pretty significant. If it's hard picking it up, you're going to lean towards the constrictive. All right, left ventricular size and function on both of those is normal. So again, not a distinguishing factor. It might distinguish it from other types of pathological states, but in looking at the two of these, it's not going to help. Again, regurgitation is going to be more infrequent with constrictive for the same reasons we just talked about. If you get those great big huge atria, it's definitely likely you will. So you'll get it frequently with restrictive, and they're showing that TR is a lot more likely than MR. But we know that everybody has TR anyway, so that doesn't surprise us. IVRT varies with respiration with the constrictive, and it's stable with restrictive. Now, it might not be normal, but it's consistently normal. So sort of like your heart rate. Well, let's in EKG purposes, let's put this as a comparison to somebody who has, let's say, an AV heart block. So a first degree AV heart block, you have your PR intervals are abnormal, but they're consistently abnormal. So that'd be sort of like your restriction. Whereas a third degree heart block, the PR intervals are all over the place. Okay. So in this case, with respiration, we're going to have our isovolemic relaxation time vary for constrictive, but it's going to be stable and consistent with restrictive. Now, is that one of those, is it a diagnostic feature? Yeah, I mean, it can be to some degree, but is it going to be our quick and easy one to determine? No, it's going to certainly take a lot more work, and therefore how many people are going to actually do it? Probably fewer people. So we're going to lean more towards our other features, but if you needed to prove it, this is not a bad one to prove it with, okay? But if I'm going to be looking at respiratory variation, what do I need to do?
Lower that sweep speed all the way.
Okay, so here's going to be a trick question, sort of. Yes, I mean, if we're going to see a bunch of them together, that would be a good line of thought. However, from what we're talking about as far as being able to measure a short distance on a time, horizontal time, what would be more accurate to measure it? Make it longer. Okay, so you might want to do that to distinguish it to get more accurate measurements. But to Mike's point, we want to see more waveforms. So what we need to do is take a couple, look at the respiratory phase, slide it over, and just scroll your image over and measure a couple of those, one during inspiration, one during expiration, or maybe a few of those waveforms, and see if there's a change. But again, for more accuracy on measurement, you actually want to increase your sweep speed rather than decrease, because decreasing, it's going to cramp it together even more, and putting your calipers on a really tight distance is just going to be less accurate. So again, IVRT as far as a diagnostic tool might not be your jump. You're not going to jump to that right away. And here's another distinguishing factor then. So the respiratory variation, this time you would decrease your sweep speed because we want to look at the peaks of the E waves, just like during tamponade. And the constriction is going to be an exaggerated greater than 25% variation between inspiration and expiration on that peak E wave during constriction. But restriction is going to be normal. What is normal? So let me ask, in a normal situation, does it vary?
No.
Very little.
It does vary, less than 25%. So it does vary. So don't get too excited if you see that variation. Just you're looking to see if it varies by more than 25 or 35%. Okay. But don't be thrown because it does vary slightly, because that is normal. Color M mode. So this the propagation velocity, or the VP. So in constriction, it increases. It's greater than 55 centimeters per second, whereas restrictive, it's reduced. So if I'm saying it's increased, does that mean it's a more gradual slope or a fast or a steeper slope?
Gradual.
It's more gradual, yes. So it's more out. A reduced means that it's going to be very steep. Okay, so restrictive physiology, and again, with the pressures the way they are, it's going to be very steep. That's again not probably one that people are going to jump to immediately, but it is a possible distinguishing factor. So on this chart, the big ones, atrial size, tissue Doppler, and respiratory variation. Those are your three big ones to differentiate.
Thank you.
Does that help your question?
Yeah, actually it does. I really needed just a nice review for that. So that was good. Thank you.
Yeah, so on the slide, I think the slide before this, I kind of just go over those initial differentiating ones. So yeah, that's what this is. So there are other things that are there that are possible, but they're just less likely to have to deal with.
Yeah, and I like how you're just like the main points are these. Those are really helpful, especially since we're looking at the big picture of things. So
yep, definitely. That was a good volley.
So the propagation velocity is color M mode through the mitral valve. It's when it looks like troll hair,
Yes,
troll doll hair.
it does. I love your analogies.
And so when it's straight up and down, that's good or bad?
So you want it to be kind of like that. If it's less like this, that's going to be more towards the constrictive side. If it's really, really steep, straight up and down, that's a little bit worse. But generally speaking, it's kind of like this.
Does it close like this and then it comes down like this, right?
So remember with your propagation, you typically, it typically shows like, let me see if I can find a picture of it. It typically shows like a double aliasing thing, and they're both kind of, they're kind of two together and they kind of slope like that. So let me just see if I can pull up a picture.
Yeah, this is one of those things on my list of things I don't know. I kind of know it.
Yeah, and you know, I wouldn't put it as a huge priority, but you might see it sometimes. And you know, keeping it in your back pocket is another tool to be able to look at these things. You may be in many labs that don't use it, and say you're splitting hairs between a lot of different data. It's like, well, one more piece of data that might help is this. So that's where you want to do
Okay.
it. So as I'm looking this up, tell me, what view do you obtain it from, and what anatomical landmarks are we looking at?
Apical four chamber, mitral valve. You want to look at you want to look at the diastolic versus systolic, and is it holo? I don't remember if it's sys or holodiastolic, right?
So we're looking at the opening of the mitral valve. It is from the four chamber view, from the apex through the middle of the mitral valve. So you put your cursor through as if you were going to take your mitral inflow. And we're going to look, so stick color on first and then run your cursor through it and then run your M mode. And so what we're looking at, and let me just pull this up on the screen here. So what we're looking at is, so your valve leaflet is here. Okay, that's where the tips are. So that's where the line is coming down through. Remember, this is actually a poor representation. Their line is actually not going through it at all. So I don't even know if that's accurate. Let me find a better one.
You want the line to go through the valve, right?
It should go through the valve. Yeah, that's why I don't like that picture. The heck? They all got the, oh, no, this one's accurate. So you can see this line here going through here. You can see this line is going through there.
Mhm.
So that is through the center of the valve. So that's accurate. This one is, this looks like it has an increased sweep speed. So right off the bat, you can usually tell if the sweep speed has been increased or decreased. This one's more of a normal sweep speed. It does look like the rate is a little bit variable just on a quick eyeball. But notice how it's more prominent on this one. Notice how we got an aliasing group here, but we also have an aliasing thing there. Okay, they almost always have like a double appearance to it. Let me pull up another one. Again, here you typically, you take that first aliasing group is what we're going to measure the slope on. The second one is just kind of just the way the flow goes. That would actually be like your A kick.
Yeah, is that like the
That you
E
drove.
wave and then the A wave?
Yeah, it is.
Okay.
So that's why you kind of have that double kick when there's not a fib, but we're going to measure the E wave slope. And what we're looking at again, so this is mitral valve leaflet here. Your apex is up here where it's running through the apex.
Mhm.
And we're looking at the progression from when the valve opens towards where that aliasing goes. Technically, we're looking out 4 centimeters towards the LV apex, but measuring the slope is what's important. Does that help on that? I mean, it's kind of a simple measurement to do. It's not that difficult, but it might be not done that frequently in labs.
So can you tell me again, what does 55 mean?
So that means 55, it's a slope. So it's 55, is it millimeters per second? It is, so it's a distance versus time. So they do, yeah, it's centimeters per second. So like this one here is in centimeters per second. This is reduced. So this is very steep.
So steep is,
So this would fit that
Bad.
more of a restrictive physiology.
oh,
So this one, I'm just grabbing a couple that have some differences here. So you can see a gradual slope there. You can see a steeper slope there.
so going too
55 is
fast
kinda
is
your-
bad and going too slow is bad.
Yes. Yeah, generally speaking, it's going to look something like this. If you
Okay.
notice it's like really, really steep, then you might pay attention to those numbers more closely.
Okay.
Yeah.
That one looks like a cool pineapple.
Yeah. Just trying to see if it had any. Let's throw in,
I did it on Graham once.
yeah, it's not very hard to do. Here's one that kind of shows normal versus
Oh,
so
it's our chart.
this is on your normal diastolic chart kind of thing. So there's a normal. So normal often looks like that. It is fairly steep, usually. So a restrictive is going to get steeper. This one doesn't show it very well because it looks actually less than the normal. But impaired, it gets less. Pseudo normal gets even less, and then restrictive starts to go back the other way to the point it gets very, very steep. And it does have some correlation with that slope of the decel time.
Yeah, look at it.
So looking at these waveforms, you can see it kind of mimics that, although I don't think the last one shows it very well.
Thanks for going over that.
Yep. Again, it's a pretty easy measurement to do. If your lab's not doing it, you might do that if you're kind of, trying to decide between if it is or isn't, certain pathologies. I like new techniques and stuff like this. So, where else have we talked about color M mode being useful in echo? So this is probably one of the more common places it's used for how much it is used. But where else might you use color M mode?
Wasn't it timing for regurgitation?
Yes. Okay. So it's helpful if we're looking at like a prolapse valve. Because remember, prolapse initially shuts, but then that leaflet slips and then it comes later. Whereas if it's holo diastolic, then it's that's an indication that it's just something wrong with the leaflet. There's just a total opening, or it's a flail leaflet or something like that. Yeah, so stuff like that. You can use it on any valve technically. Just depends on how you're going to use it. You might be a little bit creative with it. But if you're going to do that too, just let your doctor know what you're doing, because sometimes the doctors don't know what you're going after. You'll be like, how's this help me? Or, if a doctor doesn't understand why you're using a certain picture, that can actually lead to inaccurate information on their diagnosis. So they may actually ask you to delete those images, because if it ends up in a court of law and he doesn't know how to deal with it, or she, that could be bad. So just make sure your doctor's on the same page as you are with that kind of stuff. But sometimes they'll like that you've added these new types of techniques and stuff, and it might be helpful to them and they might enjoy that. But just communicate that. Communication. Good. So let me do this. Let me.
Is there any way you can go over the pathophysiology of tamponade?
Yes. Let me do something real quick here first, just to throw it out there because it was on my mind.
No problem.
And let's do this. I'm going to try to make this not so obvious. Now's the time I can trick you a little bit. Okay, if I
As
see,
opposed to your tests? No.
Yes. Yes. I try not to be tricky on tests, but this is a time where I can be intentionally tricky and not ding points.
There you go.
All right, what does that
I like
waveform
that.
tell me?
Oh, I know. I
Okay,
think.
don't answer it yet. All right, who never talks on here? I want somebody who never talks.
Ella, Graham, I'm looking at you two.
Nice, Michael.
I was thinking about them too.
They're both very smart. They know what it is. I know for sure Ella knows what this is. She just doesn't want to say it.
Oh, we all know that Ella knows what this is.
This is a safe zone right now, so nobody's going to be judged for getting it right or wrong. Tell me what you think it is.
Ella already blared it out before all of us even peeped a word.
Probably.
Wait, really?
Yeah, but we didn't hear you. So what was it? More specifically, I didn't hear you. I'm good at waiting. What do you guys think it is?
It looks kind of like hokum, doesn't it?
That looks absolutely like hokum. Yes. Good. So what do we call that shape?
Dagger or shark tooth.
Knife.
Dagger shape. I like shark tooth, but you're not going to find that on a registry. Dagger shape is what they'll call it. And so what is this? So tell me about this waveform. What are we seeing pathophysiologically? So we are running the cursor through what structure from what view?
Aortic 5 chamber, I want to say.
Okay.
Do we do this in
Or
3 chamber too?
you can also do this in 3 chamber, yes.
Okay.
So either one is perfectly acceptable. So we're running through the aorta, which means that we're also running through the
Obstruction.
LVOT, right? So we're running through that entire area. Is this pulsed wave, CW?
Continuous wave.
Okay, it is CW because we get usually a spike in velocities. We might initially run through with a pulsed wave to see locationally where it is and then put a CW through it. But when we see this, so tell me about the first half of this waveform. What is that telling us? So if I covered up the second half and just saw the first half, what does that look like?
That notch is a bit weird.
Normal aortic flow.
Yeah, I mean, up to this point, we got a normal aortic LVOT type of flow going through there. And if it was to finish, we would see it kind of peak around here and then go back down. But then we see
But
this
it hits
second
that
spike.
obstruction and it was like, whoa, and then
Yes. And then we get a dynamic obstruction that occurs halfway through the cycle or partway through the cycle. And that's when we get that big spike in velocity, giving us that dagger shape of that extra spike. And usually this is going like probably about a third more than the regular waveform would have or more. So it spikes pretty significantly. So let me just show you the rest of that picture. I took it out so it didn't point it out. I think this one probably shows it even better, but those spikes, you can see that definite dagger shape like that. So anytime you got that weird starting into a regular type of a shape and then it spikes partway through the cycle, that is a dagger shape. And you should definitely be thinking of hokum. Now with hokum, what other things go with hokum? How do you diagnose hokum?
Hypertrophy.
mass index.
Okay. So specifically what type of hypertrophy?
Anterior septum.
So 2 acronyms that we have.
And Ash and Sam.
So ASH has to do with the type of hypertrophy, which is asymmetric septal hypertrophy. Okay. SAM is what?
Since systolic anterior motion.
Systolic anterior motion of
Mitral valve leaflet.
Of the anterior mitral valve leaflet. Yes. So where am I going to, so I can prove ASH by looking at my, and you can get both of these from peristernal long axis perspective. So our first picture. So, so we can see that. And what does it mean when I'm calling ASH and I see that anterior, that asymmetric septal hypertrophy? What am I showing?
The differences between the anterior to the posterior wall.
Yes, and particularly close to the LVOT area, as opposed to the posterior wall and even the apex and stuff like that. So it'll be a very bulky and septal near the apex. And then our SAM is, you can see it in 2D, that kind of flipping up in when the valve's closed, it starts to go upwards towards the septum. And if you're taking the M mode of that, you can see it jump up in the M mode, but you can also see it in 2D. So those are the proofs that we need to show this along with this waveform. And that's a diagnostic images for hokum. Good. Sorry, I had to share that. So Kelsey, let's go back to your question.
Oh, okay. Okay, so there's a portion in the book that I have read this 1,000 times and I still don't get it.
All right.
So it's on page 225 of the new Feigenbaum book.
Okay.
And it's a pathophysiology section about cardiac tamponade, relating the intrapericardial pressures to the intracardiac pressures and so forth.
Yes.
I just need someone to explain it to me like I'm 5.
I think the best way, because when you read it, it just gets confusing, honestly. For me personally, I like the picture. So figure 9.24, which is on that same page, 224. I think that shows us best. So first of all, let's just look at normal. So what is the difference between, so now what we're doing is we're looking at the waveforms of both the left heart and the right heart, and we're looking at the mitral and tricuspid inflows as comparisons, and we're looking at the LVOT and RVOT as comparison. So first of all, where do we take those from? So let's start with the RVOT, LVOT. What images do we take those from normally?
Peristernal long for RVOT and short for RVOT, and then 5 and 3 for LVOT.
Good. So definitely know where to get those, because if you need to jump to these quickly, you need to know what perspectives, what images to jump to evaluate them. Good. And so in a normal situation, they are So let's look at our expiration versus the inspiration. Let's look at mitral compared to tricuspid. So during inspiration on the top image there for the normal, all of our waveforms are similar in relative size. So remember that tricuspid's always, or the right heart's always going to be lower than the left heart as far as that goes on normal hearts. Okay, and relative to each other, so during inspiration, they're kind of closer to equal. And what we're talking about is the VTI on the RVOT and LVOT. And just looking at your overall waveform, you could also do VTI on your inflow of tricuspid valve and mitral valve. Okay. With expiration, you'll notice that the left heart stuff increases, relatively speaking, more than, and the right heart kind of decreases. Okay, so notice that those VTIs would be bigger on expiration normally. Compare their left heart would be bigger than the right heart more significantly. So that's normal. With tamponade, with all the other stuff that we've got going on, it becomes more accentuated. And so you'll notice that we'll start on the bottom with the expiration. You'll notice that the mitral valve increases a lot during expiration, and the tricuspid valve gets smaller on those numbers. And during inspiration, it changes, it goes opposite. So the tricuspid becomes a lot more significant for both of those, and the left heart stuff goes down. Okay, so it normally goes that way to a little bit, but it becomes a lot more accentuated right to left. And so again, with a tamponade situation, so whether it's a constrictive physiology or just the fact that it's a huge pericardial sac with really high pressures in it, which is what's causing effectively our tamponade to occur, the heart is, and going back to those Dr. Najib lectures, you can see that that heart kind of gets stuck in that space. There's so much pressure around it, it can't fill. So I've only got so much volume that can get in there to start with. So it's either going to go into the right side of the heart or the left side of the heart. And so one of them is going to dominate during a part of the cycle. The other is going to dominate during the other part of the cycle. So in inspiration, the right heart is going to dominate and those numbers are going to get bigger. And during expiration, the left heart is going to get bigger and dominate during that part of the cycle. But it just becomes a lot more accentuated. And that's also where we're going to look at our variation between our E and A peaks. So looking at those peaks, again, during inspiration, I expect that my tricuspid valve E peaks are higher. And during expiration, my left heart ones become a lot higher. And again, the LVOT and RVOT could also be used as a comparison as well. Typically, we look at the tricuspid and mitral valve peaks. In addition to that, then we also look at the collapse of that right ventricular free wall and the right atrial free wall during when it's supposed to be open. So that's going to be during diastole primarily. And so again, the concept is from a pathophysiology standpoint, the idea is that the pressure becomes so great outside that in diastole, that pressure is higher than the inside the chambers are, and that's what's causing that to collapse. And the pressures and the waveforms and stuff change because it's all relative to the pressures and relative to the amount of blood flow allowed to get into the heart during those parts of the cycle as well. I don't know if that helps at all. I like to go back to I like to go to that table, that picture, that figure 924. I think that's where I'd probably spend my time. You can maybe go through those Dr. Najib lectures again and kind of listen to his talk on tamponade and see if that makes a little bit more sense. He'll explain it. He'll spend an hour explaining that. Which is
For
good.
sure. Like I understand the charts. For some reason they just make sense. But when it's broken down into that dumb paragraph, I'm like, okay.
Yeah, I personally don't like reading the paragraph because I get confused about it when I read
Yeah,
that.
because they
So,
talk about equalization of pressures, and then I'm like, whoop, I'm gone.
Right. Yeah. So the essence is that because of all the pressure outside, the right and left have to take turns. One dominates during one part of the cycle, the other dominates during the other part of the cycle. So the dominant one for inspiration is basically your tricuspid valve. During expiration, your dominant one's going to be mitral.
So Scott, just for my brain to just completely oversimplify everything that was just said, tamponade, tricuspid bigger, no good. That tamponade.
Yes, but you got to associate it with the phase of respiration.
Okay.
So yeah, tricuspid, bigger, inspiration.
Okay.
And expiration will be mitral.
it kinda
Expiration
just
should always be mitral.
Yeah, and
then
just remember when you're
inspiration
looking
should
at
be just equal.
yeah, and when you're looking at those, you're looking at a greater than 25% variation from E wave to E wave within its own. So tricuspid and then mitral will be separate, greater than 25% change.
Okay.
Nancy.
I'm just trying to put in my body.
Okay.
Inspiration, expiration.
Yeah. Yeah, I mean, I don't go into super detail on that. It does get to be a very confusing topic. Just know that it's the fundamental physiologic issue is because the pressure outside of the heart is kind of encapsulated inside that pericardial sac, and that's what's causing those changes. And just knowing that, like the constrictive physiology is, you're kind of a limited space, and there's only so much fluid can get in, and when it gets so bad, it's going to start affecting the filling of both chambers, and it gets to the point where only one chamber can really fill effectively at one part of the cycle. And so overall, you're not going to get an effective flow through the heart and therefore through the entire body. Remember the tamponade, typically we've got a very fast heart rate. We've got these fluid volumes might be low. You might, if you were to look at this, you might also get like on your M mode of your aortic valve, you might get a curving of that box at the end because the cardiac output might be low. There's just other things like that that you might see go on. And obviously this patient's going to be quite symptomatic as well. And my last question with tamponade is, what should you do about it?
alert
Emergent,
the doctor.
don't leave them alone.
Get the process moving. Yes. And but always, as a fundamental, always make sure your patient is taken care of. I did have a case that I worked with a few years ago, just as a consultant. The patient stepped out of the room. The patient had fainted, fell on and hit their head on the machine. And turns out, long story short, that the hospital was being sued and the tech was being sued because of negligence. And so make sure your patient is safe, is my short take-home message. I don't know whatever happened with that, but just note that just weird things like that can happen. And you just want to make sure that you've done everything you can that's reasonable to make sure your patient is safe. So that means having somebody else watch them while you step out of the room, or having somebody else go get the doctor, or whatever it may be. And just making sure that you show the appropriate images on the packs and send them across so the doctor can have some good information to go off of to make a decision. Incomplete information doesn't help. Is it cat nap time? Nice. 10:45. All right. All right. Other questions? You guys know your scallops? I'm just flipping through. So that's page 286, just showing the scallops. Know your relative perspectives from our transthoracic. How would you see it in transesophageal, and how would you see it from a surgical perspective?
I just remember that surgeons are egotistical, so their way is right, and they read right to left.
That is
We're
true.
opposite of that.
That is so true. Good. Let's talk about prolapse for a second. How do you determine prolapse?
The jet will typically be centric.
Okay, so if there is a jet there, yes, it will be eccentric, and it's usually going opposite the direction of the leaflet that's causing it. So if the leaflet's over here, the jet's going to go there. That is true. But how do I diagnostically diagnose a prolapse versus something else?
Isn't it color and mode that we use to determine whether it's during the entirety of systole or only during a portion?
That can be helpful. But from a 2D perspective, how do you diagnose it?
By seeing it, you can see it coapt and then slip back.
So what anatomical parts do I need to evaluate compared to other anatomical parts?
The leaflets, the mitral valve leaflets.
You need to look at those tips.
Okay, so the tips of the leaflets, yes, compared to what?
The annual plane.
To see
Yes,
the
so
annulus.
the annular plane. So the annulus. So say these are my annuli. Okay, I draw an imaginary plane through that. If that leaflet goes down past it a certain point, that's when it becomes prolapse. If it just goes down to it, it's not prolapse. Okay, so the key on prolapse is to make sure it goes past that annular plane. So you could even draw a line through the annulus, and as you're watching it, see if it goes so much past that line.
Is it 2 millimeters?
Yeah, those numbers might vary a little bit, but it's at least 2 millimeters. Yeah. The more it goes, the worse it becomes. And then at that point, if the leaflet tips are still pointing in the correct direction, then it's a prolapse. If it's pointing the wrong direction, going back into the chamber, you know, it's a flail. Good. If I tell you that you're seeing a hockey stick appearance, what thoughts does that elude in your mind?
Mitral stenosis.
Stenosis.
Specifically caused by
A jet.
It's
rheumatic
leaflet
fever.
tethering, isn't it?
It's rheumatic. It's rheumatic fever. It causes rheumatic mitral stenosis specifically.
Ah, rheumatic.
Yes. That's a good one. And worldwide, that's the most common cause of mitral stenosis.
The same would go for tricuspid stenosis, correct?
I don't know if it's the most common cause of it, but it would probably have a similar appearance. It's just a lot. If they've got a rheumatic disease, it most often affects the mitral valve significantly. Tricuspid valve is still big enough that the mitral is more likely to be affected first. But again, what process affects one valve because of that type of process is likely to affect all valves. That is true. Just like fen-phen cases, we often did our studies looking at aortic insufficiency. It didn't mean that it didn't cause mitral insufficiency, tricuspid, and pulmonary as well. Same process happens, but aortic was the one that they're most concerned about. Sweet. What does it tell me, or what, when I do a TVI tracing of a waveform, we'll just throw it out there as mitral valve waveform in this moment. What is TVI telling me? What is that measurement doing?
Isn't that the amount of blood going through the valve?
Yes. So it kind of gives us a mean. It can give us a mean pressure gradient. Remember, the pressure is derived from taking all those instantaneous velocities and applying it to Bernoulli, 4v squared, getting us our pressures. So that gives us a mean pressure. We can get peaks as well out of that. It can be described in centimeters as we look at the track over the whole, the whole thing. But the key is that we're basically, for every one of those dots, we're taking a peak instantaneous velocity at that moment. And when we do a mean, that's averaging those all together to give us our mean.
So then the centimeters portion of that would be applied to valve areas.
It depends. I mean, so we use the centimeters on TVIs quite often for calculations, like when we're trying to calculate the area of the aortic valve, stuff like that. It doesn't necessarily say that that is the valve area, but that distance over that is applied to the equation to help derive that. Yes. All right, steeper slope for a steep slope would be severe for which valve, aortic or mitral? So an aortic insufficiency or a mitral stenosis, which one? A steep one would be more severe for which one?
AI?
Aortic, yes. Good. But they can look the same, right? So what things would make it not look the same? Or what things would tell you that it is one waveform versus the other? Say if I just threw it up there, I didn't give you any other information, which one would tell me that it's a mitral versus an aortic? What pieces of information would give us that? Kelsey.
IVRT.
Okay, so IVRT, yes. So that's one. So that tells me that it's which one?
It tells me that it would be aortic if there is an IVRT.
So if I have an IVRT and I just gave you the waveform, say that again, which one would it be?
I was thinking aortic.
So if I have an IVRT and an IVCT, then I'm probably looking at a mitral stenosis. Because remember, a regurgitation happens immediately. So there is no IVRT or IVCT. Okay, so regurgitation is going to happen right away.
Scott, is the more severe slope though AR? I thought somebody said it was AI.
Yeah, AI, AR, same thing. So regurgitation or insufficiency, but it's aortic nonetheless. Yes, a steeper slope. So disconnected from our IVRT discussion.
Yeah, I was thinking, I was confusing stenosis, sorry.
Yep. No. Sorry. So our steep slope on that was AI. Yes. A severe mitral stenosis would be a more gradual slope.
Well, stenosis would be the opposite. It would be on, that's what you're confusing your MR with. So it's below the baseline.
Well, on that particular waveform, the AI would look the same as your MS would be.
Yeah.
And those would be, depending on your perspective, could be above or below the baseline.
I thought MS is always above the baseline. AR is always above the baseline. MR is below and AS is below. I thought it's always. So when is it not?
From our usual perspectives, yes. But if I jump to a right parasternal view, for example, with a CW probe, now it's inverted.
Which we're not really experienced with yet.
Right. Yeah, it could be various perspectives, but correct. So just remember that when it comes to the IVRT, IVCT, if it's there, you're talking about a regular flow. If it's if there is no IVRT, IVCT, it's a regurgitation because regurgitations happen immediately.
Because it never closes. There's not, it's always leaky, right?
Right.
Okay.
Yes. All right, so I've got a patient that has, we'll say they're 70 years old. We're scanning away, they're barrel chested, they're hard to see, of course, they all are. I've got something that's kind of hypo to isoechoic to the muscle, floating in. It's kind of protruding from the apex a little bit into the chamber. What is my differential?
Thrombus.
Thrombus is a differential, yes. Can you diagnose thrombus on that?
No.
Okay. So first of all, characteristic wise, is it concerning that it's protruding out into the chamber? Yes. So it's less stable than it could be. Good. So it could be thrombus. What else could it be?
Mass or a tumor.
Okay, mass or tumor. And less likely, but possible.
Is it non-compaction?
Okay, probably not non-compaction, but good thought. If it was more attached to the wall, I'd say maybe. Not going to totally rule it out, but it's a lot less likely. What's another thing that could grow there? Not very commonly. It's most often attached to the tips of a valve.
Could it be a vegetation?
Vegetation could happen. So those are three differentials. So how do I differentiate between those three?
Vegetation is blood test. Thrombus is looking at Doppler, seeing whether the blood is stagnating, and mass is. Someone help me out here.
Those are great thoughts. Good. And so we could use contrast to help see it better, right? Yes, the blood tests, if we're concerned, we're looking at your patient history, seeing if they've got recent infections, stuff like that. Because remember, we don't want to rule out that it's a vegetation because it could be, even though it's not attached to a valve. Remember, that's an endocarditis type of a process. So that process might be there. But if it's between, so you saying about the movement of the blood comparatively, so let's explore that some more. So if I'm between now thrombus and mass, from an ecotech perspective, how do you differentiate that? You mentioned something about the blood flow.
Yeah, like whether the blood is like really stagnant around the supposed thrombus.
Okay, so if the blood is stagnant, so how can I tell if the blood is stagnant or not around that?
Wouldn't that be color Doppler or pulse wave Doppler?
Okay, so you could do color Doppler would be helpful. Pulse wave might help you.
A smoke effect.
Yeah,
Okay, there could be some
smoke
smoke
Spontaneous
effect.
contrast. Maybe.
What about the walls?
They probably will be less mobile.
Are you
Okay,
talking about
so-
borders?
So I'm looking, so yeah, we want to see the borders. So we want to define the borders. We'll measure it, all that kind of stuff as well. But the walls themselves around it, if the walls are squeezing, which one is it more likely to be?
Mass.
More likely to be mass, yes. Unless they've got a history of AFib that's intermittent, that could happen as well. But if I've got aneurysms, if I've got a wall segment that's out because of a heart attack, if I've got scarring and it's just akinetic, that type of stuff, I'm going to probably lean more towards thrombus. Could it still be a mass? Could be, but those are going to be things that help us distinguish between it. So if the rest of the story around that makes sense for one or the other, is kind of how it's going to help guide you through your differential.
Are we saying that in a report though? I mean, aren't we just giving them the information and then they're deciding whether it's a mass or a thrombus or?
So they will decide. You can suggest and they can edit it. And so we can suggest that, but we'll tell them that story. We see this pedunculated, echogenic or hypoechoic. In your report, you can call it a mass or something that sticks out, protrudes into the chamber, et cetera. And you can say that there's akinesis around it, there's an aneurysm around it, stuff like that. So I would comment on those things in the report for sure, and then suggest that it's likely to be a thrombus. Give the proof and stuff, describe what you just did, describe its contents, et cetera. Or if you saw something protruding out there, you describe what it is, its size, and say the wall motion around it is normal. Suggesting a mass or a tumor or something like that. Remember in your report that you can comment on those things and the doctor has the right to edit it. just make sure that that ends up in your comments, your summary comments at the end, so they don't miss it. In fact, if I'm seeing something like that, if I have the opportunity to, I'm probably going to talk to the doctor and be like, hey, I see this thing here. This is what I want to say about it. And they may, you want to make sure they see it. You don't want that to walk out of the room and they diagnosed it as normal. So you could have made a comment in the body of the report where you're commenting on the LV and the chamber and stuff like that. But if you didn't make a comment on your summary, sometimes that's all the doctor looks at. They throw it on. They didn't necessarily look at the images carefully, and it's gone and it gets reported out and they miss it. And that person has a stroke and finds out it's because of that. Then it's going to come back and bite us in the butt. So you definitely want to comment on it and make sure they're aware of it. So make sure that that finding section at the end, or that summary, clues in the doctor to make sure they pay attention to that. They can edit that, so they can still, if they disagree with you, they can change it and before they send their final report. But in the echo world, you're typically on the same platform writing your report, so you need to make sure it's a good, thorough report, and you're describing everything as completely as you can. They don't want to be in a clinical setting. They don't want to be as concerned about trace, regurgitations and stuff like that. If you see them, you might comment on the body of the report that there's trace regurg, something like that. But in the summary, you're not going to worry about it because they aren't concerning. I like to do it so that we're trained to see it, but it's not a concerning thing. And the reason being is if a doctor says something about a regurgitation, it doesn't matter what you said the severity of it is. If the provider gets that, particularly a provider that doesn't know a lot about the cardiac world, they get really excited and they start ordering all kinds of unnecessary tests for something that's a trace amount. And, in the reality, the doctor just doesn't, it's not that important. But some other providers get very excited about those things. So make sure that we only comment on the things that are necessary to deal with. But often we'd make those reports and the doctor will read it. They might modify it slightly, if any. And once they get to really trust us, they'll pretty much they'll look at the images and see if they agree with it. And they'll pretty much sign off on exactly what you said if you said it right. That's normal in the cardiac world. So does that mean we have to know what we're doing? Yes. Where might I use commonly these days strain imaging?
Cancer patients,
Yep. And what are we specifically looking for?
changes before, during, and after therapy.
Yes. So we're looking at systolic and diastolic function just to see how well that patient's tolerating that therapy that they're getting. They might increase the aggressiveness of that therapy. They might decrease it and back it off because it's starting to affect the heart, that kind of thing. So that's where we're going to use that. What does what information does strain imaging tell me?
Just deformation and the rate of deformation.
Yes. So it's like digitally palpating something, right? So we're seeing the stiffness of that. That's why we do the deformation to see how fast and how stiff it is what we're looking at, the stiffness and the rate at which that stiffness is changing. So that's what we're looking at. Is that the only application of strain imaging? No, there's a huge number of things that it could be used for. The second most common one is probably for amyloidosis. Looking at the stiffness of the muscle and stuff. And there's a particular characteristic that they see on a bullseye type of view from at the apex. And I think they call that, let's see if I can find a picture of it. It's like a cherry appearance. Let's see.
Wouldn't the other feature, I thought it would be wall motion abnormality.
For amyloid?
No, just for using strain.
Oh yeah, you can use it for all kinds of different stuff. Those are probably the two most common, heavily on the cancer therapy. The chemotherapy is where it's used most by far. but it could be used for a whole variety of things. Let me just share my screen for a second. So amyloidosis, I don't know exactly how this is, but this is,
which is already,
it's called the cherry pattern. So the bullseye appearance. So basically where I've got red seems to be where we have the most amount of motion. And the cherry pattern is that on the bullseye appearance that the cherry is the dark red in the middle at the apex. You can see that the whole rest of the heart is very kind of, it's not moving a whole lot. Let's see if I've got that right. Yeah, I'm pretty sure it's that the apex is kind of preserved, but the rest of it's kind of stiff. I might have that backwards, but I'm pretty sure that's the case. If I could see one of these a little bit stronger. Your color bar at the side gives you an indication of where the stiffness is. I believe the top, the blue, is where it's most stiff, and the bottom is where it's the least stiff. So I'm pretty sure that's what it is. But it's called the cherry pattern, and that's specific to amyloidosis. Just FYI. That's not on my test, but. Where's 3D useful in echo? Where do you think it's most used?
Wouldn't it be like stroke volume and ejection fraction? Like, because we can conceptualize the heart in just one solid plane.
Okay. What else?
I was about to say, I feel like you're about to say, no, that's completely wrong based on your face.
No, my brain is going off in about 10 different directions right now. That's all.
I couldn't tell if that was an okay, right, Michael, or okay, you're wrong, Michael.
Yeah, like, okay, you're a dumbass. Moving on.
Honestly,
I know.
I lost track of thought. You're probably right, Mike. I can't even remember what I asked. What did I ask?
What is 3D echo most useful for? Or something similar to that.
Okay, yeah, that was my question. Okay, so let me revisit that. So tell me your answer again.
It was because we can better conceptualize like stroke volume and ejection fraction in just one plane. Because we're cutting off a little bit in 2D, so it's not as well.
So I will go with that initial reaction of that's an okay answer. But where do you think it's most used?
Most used.
Do you think we use, first of all, do you think we use it mostly in transthoracic or transesophageal?
Esophageal, and I was thinking for like valve replacements, valve repairs, things like that.
Yeah, it is mostly in valve replacement. It's for valves mostly. And so whether it's repair and stuff like that, that's probably most commonly where it's used, but it is on valves the most. Now, why do you think it is on the valves the most?
That way they can identify the scallop that's the problem and like look at where the, I guess, look at where the problem is.
Yeah, where the problem is, and not all valves have scallops, so it could be aortic valve, could be other valves and stuff as well. So, but getting the valves and seeing the detail is important. Part of why I would suggest that it is, I'm not saying that this is hard and fast why it is, but when we're looking at wall motion and looking at that big of a picture, classically speaking, 3D, what is our biggest problem, do you think, on imaging something of a decent size on our ultrasound systems, generally speaking? What do you think is our biggest struggle in echo?
It's going to be too slow.
Yeah, speed. So frame rate, right? So frame rate, the bigger the frame, the more time it takes to form the frame, and therefore multiple frames, it gets hard to see that data. So if I've got a very large structure and I'm in 3D, so we don't have frame rates now, we have volume rates, which are a huge stack of frames packed together to create a volume. But then I've got to get enough volumes repeating in a fast enough time to be able to show that in real time. So our volume rates have to be quite high. So one of the reasons that we look at valves more closely than we do the entire heart is that the size of the volume, the smaller that we can get the size, the faster it gets to be reproduced. So honestly, a lot of that's because, yes, it does give us some great clinical information on the valves themselves, but with the transesophageal, I can get these small sectors. I can get these small volumes of that valve in that data so that it's a decent enough speed. Even with that, we have a problem because we typically have to, what they call stitch together 5 to 7 volumes of 5 to 7 different beats. We have to kind of patch them together to create an image. And that's because the ultrasound systems have a hard time keeping up with that volume rate. And so the valves are that way because we can get that smaller volume. So the newer systems, we can get into more 90-degree size sectors with high enough volume rates to be able to see that. So really a big part of that is because where we started with 3D, it was more likely that we would get those small volumes in that format rather than getting the entire heart in a big volume. So that's a big part of it. The biggest issue with that from a physics standpoint is cooling of the crystals. So it takes a lot of energy for those to create those images, and the crystals get hot. Okay, and there's FDA regulations on heat allowances for that. So, you know, like the Siemens product, the SC2000 system had that liquid cooled transducer, and it would flash all the crystals at once instead of writing them line by line all the way down the grid. And so I think for that reason, we've actually got more imaging being done on valves in 3D than we do the entire heart. But in the future, that certainly opens up more possibilities now that we can keep up with those higher volume rates. But yeah, when you're clinical, you're going to see more of that in transesophageal work. What else? What are the two types of grading mechanisms or studies that that show us dissections on an aorta?
That's I know one's like a baker.
DeBakey.
and DeBakey.
DeBakey?
Yeah, DeBaker. That one.
DeBakey's like a baker.
Sorry, I just thought like food, and it, you know, resonated with me.
Good thing it's multiple choice. So DeBakey, and what's the other one?
Danford.
Okay, good. So just know the subtle characteristics between them. As far as concern goes, from a cardiologist perspective and wanting to do more aggressive treatment for it, what becomes more concerning on a dissection as far as distance from the heart goes?
Towards the aortic valve is concerning.
Yeah, so it's very concerning if it gets above the arch or at the arch and towards the ascending aorta for sure. Descending, it's still concerning, but it's not as concerning, and so they may treat it differently. Good. I'll use Mike's example yesterday. If we've got if we're taking a spectral Doppler of the descending abdominal aorta, and we see a holodiastolic flow, what are we thinking about?
AI.
Mild AI?
Severe.
Now, if we're seeing it abdominally, it's definitely severe AI for sure. Yes. Now, again, back in my day, we actually did used to measure how long that diastolic flow would go because it wasn't always holodiastolic. Sometimes it would only go partway through, which would indicate maybe not quite as severe, but maybe more moderate. So some labs still may characterize it that way. But if we're getting holodiastolic at the abdominal or descending thoracic, we definitely got severe.
Am I wrong in thinking just like the further it goes down and we can see it, the worse the severity is? Like
Likely,
overall?
yes.
Okay.
More than likely. Now, can you miss it by not having not optimizing your system? What do you think is the most important thing on taking a Doppler on
Wall
getting it.
filter.
Not just wall filter. Wall
Yeah.
filter may have something to do with it, yes.
Scale.
Your angle?
Angle. So if I'm coming in close to 90 degrees to it and I'm taking my Doppler, you could miss that and it could be pathologic, but you could miss it because your Doppler angles are poor. So make sure you're always less than 60 degrees. Now, it's always less than 20 degrees or 0 degrees is best in echo, but as far as abdominal aorta goes, you're not going to get a 0 degree angle. So 60 degrees or less is acceptable in that region.
Just to clear up, do we use angle correction for abdominal AO if we need to?
Yes,
Because
I
I know
would
we
definitely.
don't use angle correction for like almost anything else.
No, we don't, but definitely use angle correction for abdominal. Yes,
Okay.
you should. Yeah, abdominally and in the vascular world, the only time we really don't use angle correct is on venous stuff. But I would suggest using it. Actually gives you better Doppler information anyway. So I would personally still use it, even though it's not required. Kelsey, would you agree with that? You're nodding your head.
Yeah, absolutely. There was an older tech I worked with that's just like, well, why would you put a Doppler on there? I'm like, well, I know I'm aligned with the vessel better and I got a better response.
Well, it goes back to the concept. The closer you are to 90, the worse it is. And you start to lose that low flow information. And I think you just see it better when you have a proper angle. So
Yeah, I would say
even-
like most of their angles were like this.
Oh yeah. Yeah. Just garbage. And it's funny how much information you can pull out of it when you have a proper angle. Same thing with scale. You know, a lot of techs, especially general techs doing vascular, they tend to keep that very, very tiny spectral strip. But if you increase the size of your spectral strip and you have an appropriate velocity for the size of your strip, you see a lot more information if you optimize it. It's one of my pet peeves with general techs doing vascular. They don't understand that concept and they miss a lot of stuff. General techs are good too, but not when it comes to reading Doppler, from my experience. All right, it's 11:18. Any other questions today? You want to revisit it again tomorrow? Do you want to call it good?
It's a good
I really
question.
hate like speaking in front of a large group where my opinion might differ than the others, but I'm all about reviews. Like I feel like that's where my brain just makes connections. So I'm down for tomorrow.
Okay.
I'm down for tomorrow.
And well, the thing is, Kelsey, if they don't want it, they just don't have to show up. There you go. Problem solved.
Okay, but here's my caveat again: is that if only a few people show up, I'm probably not going to record it. Just
Fair.
because I think if you put the time and effort in being there, I think you deserve to get that information. If you don't put the time and effort in and just want to glean off what others do,
I
I'm
don't
not
think you
necessarily
didn't
about that.
record it today.
I recorded it today.
Oh, I don't see the little record light on.
Oh yeah, that's I recorded on Panopto. You don't always see. You only get that record light when I put it on when I record on Zoom, but that doesn't ever get anything anyway.
Okay,
I just do
thank
that
you.
so I can still see you.
Thank you for recording it.
Yep.
I'll be
Yeah. So
there
if everybody
tomorrow.
shows up, I'll record it. If only a few people show up, I won't. But if you have questions, we can certainly do it. You don't have to show up to it, so I'm fine either way. But again, bring your questions. So kind of revisit the information tonight and bring your questions tomorrow.
Sounds great. Thank you.
Yeah,
All right.
thank you.
Thank you, Scott.
Happy studying.
All right. Thank you.
Bye.